Hello everyone. This video is about nephrotic syndrome. Now, nephrotic syndrome falls under the category of glomerulopathies, which means there is defect in the glomerulus of the kidney. Now, one kidney has around 1.2 million nephrons, and we know the parts of nephrons, right? There is the glomerulus, then you have the proximal convoluted tubule, then you have the loop of Henle, then the distal convoluted tubule, and then the collecting duct and the draining system. Now, there is a defect on the glomerulus and the glomerulopathies, and nephrotic syndrome is one of them. Now, before understanding the nephrotic syndrome, we must understand the glomerular filtration system. Now, this filtration system is actually made up of three membranes. So, if you look into this picture here, so it is from the afferent arterioles that the blood comes into the kidney, and from here you see these cells. These are the capillary endothelial cells. So these are the first line of filtration. So these are the first membrane through which the blood gets filtered out from. And then we have the glomerular basement membrane. So we have glomerular basement membrane, and this is the second membrane, and then lastly we have the glomerular podocytes. So we have these cells that have these food processes, and between these two adjacent podocytes there is a gap. This gap is also called as filtration slit, and it's around 20 to 30 nanometer in size, and through this gap the smaller particles will filter out, whereas the bigger particles will remain outside. So these are the filtering membranes or filtration layers of glomerular filtration system. So it consists of endothelial cells of arteries, glomerular basement membrane, and then podocytes or visceral layer of the Bowman's capsule. Now, endothelial cells have fenestrations of around 70 to 100 nanometer, whereas the gap between the podocytes or the filtration slits are of 20 to 30 nanometer. These filtration layers are also negatively charged. So it's not only the size of these filtration layers that filter out the particles, but also the charges. And these filtration membranes are negatively charged. So any particles that are negatively charged coming from the blood vessels, and we know that like charges repel, right? So these charges will repel. Okay, so the negatively charged filtration membranes will repel the negatively charged particles of the blood, like the proteins. Proteins are negatively charged, so proteins are not easily filtered through the glomerular filtration system, whereas the negatively charged waste particles are attracted. Now let's talk about the nephrotic syndrome. Nephrotic syndrome is when there is mild injury to the glomeruli. So when there is injury to the glomeruli, the smallest molecules like the albumin, which is a protein found in the blood, it will start leaking out from the blood vessels. So at first there is only albuminuria. Okay, so only albumin is leaked into the urine, hence albuminuria. It is also known as selective proteinuria. Okay, so mild injury to glomeruli will first only cause only albuminuria, which is also called as selective proteinuria. Now we should also know that normally also very less amount of proteins are filtered through the nephrons. So the normal proteinuria is less than 150 milligrams per day. Okay, so proteinuria of less than 150 milligrams per day is normal. Now, if the injury is slightly higher, then more proteins like globulins. Okay, so globulins are bigger proteins than albumin. They also start leaking out from the blood vessels. So, when the injury increases, the proteins like globulin also start leaking. Hence, both albumin and globulin both start leaking out. This is called non-selective proteinuria. Okay, so both albumin and globulin starts leaking. It's called non-selective proteinuria. And when the injury is severe, heavy proteins starts leaking out, and the proteinuria becomes more than 3.5 gram per day. This is when we call it as nephrotic syndrome. Okay, so nephrotic syndrome means there is heavy protein loss from the kidney of more than 3.5 grams per day. Okay. So what happens if the protein loss is increased? It's The effect of this is that when the proteins are lost from the blood vessels into the urine, there is loss of oncotic pressure of the blood vessels. Okay, so inside the blood vessels there will be loss of oncotic pressure because it was the proteins that were responsible for this pressure, but these proteins are now leaking out through the urine. So there is loss of oncotic pressure, and because of this pressure, fluids cannot be held back inside the blood vessels, hence they will start leaking. So there will be fluid leakage into the surrounding tissues. This will cause generalized edema or anasarca. So the effect of heavy proteinuria will be generalized edema or anasarca. Now about this edema, usually this is first seen around the periorbital region, hence periorbital edema and face. Okay, so the first sign of edema is around periorbital edema. Why is this? Because skin around the orbits are thin and loosely attached. Hence, any fluids that leak out from the blood vessels will easily push the skin. Hence, the periorbital edema is more prominent, or it is manifested early in case of nephrotic syndrome. So, normally also, liver produces around 10 to 12 grams of protein per day. But if the protein loss through the urine is only 3.5 grams per day, then how are the symptoms being produced? So, why is it not being compensated? It's because the actual amount of proteins that are being filtered in the glomerulus is very high. That is more than 12 grams. Okay, so the liver is producing 10 to 12 grams, but the actual amount of protein that is being filtered out is more than 12 grams. But most of these proteins are destroyed by the cells of proximal convoluted tubules, and only around 3.5 grams of protein come out through the urine. Hence, the urine protein that we measure in the lab is only a fraction of the proteins that are being filtered out through the kidney. Okay, so it's the actual number of proteins that are being filtered out is more than 3.5 grams. With the generalized edema that we last spoke of, this edema can cause reduced blood volume since the fluids are leaking out from the blood vessels. Now, this reduced blood volume can cause two things. Okay, firstly, it can cause decreased kidney perfusion. Since the blood volume is reduced, the kidney perfusion will be also reduced. This will trigger the production of renin or trigger the RAS system. So renin, angiotensin, aldosterone system will be triggered, where there will be conversion of angiotensinogen to angiotensin 1 by renin. The angiotensin converting enzyme will convert angiotensin 1 into angiotensin 2. So there will be increase in the level of angiotensin 2. Now, this angiotensin 2 can cause vasoconstriction. So, it is a vasoconstrictor which will cause the increase in hydrostatic pressure of the blood vessel. Secondly, it can also stimulate the aldosterone production from the zona glomerulosa of the adrenal cortex. Okay, so angiotensin 2 will also stimulate the production of aldosterone. This aldosterone will now retain salt and water from the kidney. Okay, and but this retained salt and water that are in the blood vessels, now the blood vessels cannot hold these salt and water because due to loss of proteins already. In a nephrotic syndrome where there is already loss of protein, there is no oncotic pressure to hold these salt and water inside the blood vessels. Hence, whatever the salt and water that were retained by the aldosterone will also eventually start leaking out. So all these actions by angiotensin 2, the increase in hydrostatic pressure and stimulation of aldosterone eventually leading to blood fluid leaking out from the blood vessels will cause more edema. So it's like a vicious cycle, a positive cycle. So the edema will keep on increasing. Also, due to reduced blood volume, the fluids that are being leaked through the blood vessels will become hyperosmolar. Okay, since this is a blood vessel and the fluids, clear fluids, are leaking out from the blood vessels, then only the particles or the proteins and other components, cellular components, will remain inside the blood vessels. This will increase the osmolarity of the blood vessel. So when this is increased, it will trigger the hypothalamus, and hypothalamus will produce antidiuretic hormones. So ADH will be produced because of increased hyperosmolarity of the blood vessel. Now, antidiuretic hormone will also retain water from the kidneys, but again, this water cannot be held back due to loss of proteins, lack of proteins in the blood vessels, and this will further cause fluid leakage and more edema. There is loss of proteins from the blood in nephrotic syndrome, and this protein loss is in heavy amount. So the liver will try to compensate by producing more proteins. We know that liver is already producing proteins, right? So when there is loss of heavy proteins, then liver will try to compensate, but during this process, unfortunately, it will start making lipoproteins as well. So the lipoproteins will be formed. The level of lipoproteins in the body will increase. So what this will do is that there will be increase in the level of LDL, VLDL, triglycerides, and there will be decrease in the level of HDL. So this will eventually cause dyslipidemia, hence there will be risk of atherosclerosis in case of nephrotic syndrome. And also increase in the lipid level will cause lipiduria. So lipid will also start appearing on the urine, and these lipids are consumed by the proximal convoluted tubule cells, and these cells are later shedded through the urine as oval fat bodies. So these oval fat bodies will also be seen on urine microscopy. So, from the above explanations, we know that nephrotic syndrome is a clinical complex which is characterized by proteinuria. Now, we should know these values that proteinuria is more than 3.5 grams per day or more than 40 milligrams per meter square per hour or more than 1 gram per meter square per day. Okay, so you can take any of these values. Then there is also hypoalbuminemia because albumin is being lost through the urine. So the level of albumin will be less than 2.5 gram per deciliter. There will be generalized edema. There will be hyperlipidemia or dyslipidemia where the serum cholesterol will rise above 200 mg per deciliter. There is also lipiduria. And lastly, there is also a state of hypercoagulability. So nephrotic syndrome is also a state of hypercoagulability. It is because of loss of antithrombin 3 from the kidney. So not only above all the proteins, but also antithrombin 3 is also lost from the kidney. Hence, this will increase the risk of hypercoagulability. Now let's talk about the etiologies of nephrotic syndrome. Now, most of the nephrotic syndrome is due to primary glomerulonephritis. Okay? So these include diseases like minimal chains, glomerulonephritis, FSGS or focal segmental glomerulosclerosis, membranous nephropathy, and MPGN as well. Membranoproliferative glomerulonephritis can also lead to nephrotic syndrome. Then there can be also glomerulonephritis with infections like endocarditis, malaria, syphilis, glomerulonephritis malignancy like CLL, Hodgkin's lymphoma. It can be associated with drugs like heroin, captopril, penicillamine. There can be miscellaneous causes like pregnancy, constrictive pericarditis, renal vein thrombosis, congestive cardiac failure, and lastly, there can also be secondary amyloidosis. So, all these conditions can lead to nephrotic syndrome. Now, let's talk about the clinical features. There is generalized edema that, as I've already explained, the edema will first appear on the eyes or the face. So there will be periorbital edema, facial edema, and then slowly it will progress towards the limbs. And the edema is pitting type. The urine appears frothy. There is frothy urine due to presence of proteins and lipid. There is no hematuria. The RBCs are not lost through the urine, hence there will be no hematuria. The blood pressure will also be normal and the urine output will also be normal. There is hypoalbuminemia and hypercholesterolemia. There is lipiduria and hypercoagulability. So these are the features of nephrotic syndrome. So, what are the complications of nephrotic syndrome? The complications include disturbed coagulation or hypercoagulability and DIC, disseminated intravascular coagulation. This is due to loss of antithrombin 3 from urine, as I've already told you. The next complication is also infection. Why infection? Because there is also loss of immunoglobulins, so there is loss of antibodies from the urine in nephrotic syndrome. So immunoglobulins are also lost, and these can increase the risk of spontaneous bacterial peritonitis, SBP in patients, pneumonia, cellulitis, UTI, and meningitis in nephrotic syndrome. So the patient are more prone to these diseases. There is also risk of hypovolemia, loss of blood volume. There is risk of atherosclerosis due to dyslipidemia or hyperlipidemia. There can be loss of vitamin D as well from the blood vessels. And because of this, the patients are at risk of osteomalacia or secondary hyperparathyroidism. Then there can also be transudative pleural effusion or generalized edema. So fluids can leak out not only into the surrounding tissue but into the pleural space, causing transudative pleural effusion. Hence, chest X-ray is also done in patients with nephrotic syndrome. Now let's talk about the investigation part. What investigations we do? Firstly, we check for urine. So we check for 24-hour urinary protein. Now, as I've already told you, the normal is less than 150 milligrams per day. So in a 24-hour urinary protein, if it's less than 150 mg, then it's normal. Whereas in case of nephrotic syndrome, we have already explained the values of proteinuria, right? It's more than 3.5 gram per day, or more than 40 mg per meter square per hour, or more than 1 gram per meter square per day. So that's the level of proteinuria in nephrotic syndrome. The creatinine clearance will also decrease. Normally in male it is 97 to 137 milliliter per minute. In female it is 88 to 128 milliliter per minute. So the nephrotic syndrome, the protein creatinine ratio will be more than 2. So the PC ratio will be more than 2. In case of blood examination, the serum proteins will decrease. Normal it's around 6 to 7.8 gram per deciliter. The level of albumin will also decrease, where the normal value is 3.5 to 5.5 gram per deciliter. In nephrotic syndrome, it will be less than 2.5 gram per deciliter. And the level of globulins will also decrease. The normal is 2.3 to 3.5 gram per deciliter. The serum cholesterol level will increase. The normal is less than 200 mg per deciliter. It will become more than 200 mg in nephrotic syndrome. The serum glucose level will still change, where the normal in fasting it's 70 to 110. Normal in 2-hour postprandial is less than 120 mg per deciliter. The blood urea nitrogen can increase, where the normal is 7 to 18 mg per deciliter. Serum creatinine, the normal is 0.6 to 1.2 mg per deciliter. There is also increase in ESR in nephrotic syndrome. The normal in male is 0 to 15 mm per hour, whereas in female it is 0 to 20 mm per hour. And there is decrease in thyroxine binding globulin level in blood. So these are the findings that we can see in the blood. Now talking about the renal biopsy, so it is a definitive diagnosis for nephrotic syndrome, but we do renal biopsy only if it follows these criteria. So the criteria for renal biopsy include the age, if it's less than 12 months or more than 12 years, gross or persistent microscopic hematuria, there is steroid resistant nephrotic syndrome, there is persistent hypertension, low C3 level in the serum, non-selective proteinuria, or impaired renal function. So these are the criteria for renal biopsy. On the biopsy, when you do the microscopy, you will see minimal change in mesangial cells and the matrix. And on electron microscopy, you can also look for effacement of the food podocytes. So these are the findings on a renal biopsy. You can also do chest X-ray for pleural effusion. Now let's talk about the types of nephrotic syndrome according to the response or course of the disease. So before going into the types, we need to know a few things here. Let's know about the urine albumin grading, where 0 means the proteinuria is less than 15 mg per deciliter, trace means 15 to 30, plus 1 means 30 to 100, plus 2 is 100 to 300 mg per deciliter, plus 3 300 to 1000, and plus 4 is more than 1000 mg per deciliter of albuminuria. And also, the term remission of nephrotic syndrome means that the urine albumin has now become nil or trace. The proteinuria has decreased to less than 4 mg per meter square per hour. The protein creatinine ratio is now less than 0.2 on 3 consecutive early morning urine samples. Alright, so these are the terms that we need to remember here. Now let's go on to the types of nephrotic syndrome. The first one is steroid sensitive nephrotic syndrome, where the cases will go into remission, means they will follow, they will get these features within 4 weeks of steroid therapy. Okay, so the patient will now recover within 4 weeks of steroid therapy. This is called steroid sensitive nephrotic syndrome. Then there is infrequent relapse, where the relapse of nephrotic syndrome, which actually means the urine albumin of plus 3 or plus 4 or proteinuria of more than 40 mg per meter square per hour, or the protein creatinine ratio more than 3 on 3 consecutive early morning specimens. Okay, so this is what relapse means. And in infrequent relapse, this relapse will occur less than 2 times in 6 months or less than 4 times in 12 months. This is called infrequent relapse. Now, in contrast to this, frequent relapse means more than 2 times in 6 months or more than 4 times in 12 months. So if these features occur more than 2 times in 6 months or more than 4 times in 12 months, this will be called as frequent relapse. Then there is another type of nephrotic syndrome called as steroid dependent nephrotic syndrome, where the relapse occurs when using steroids on alternate days. So if you start using steroid on alternate days, then the relapse can occur, or if the relapse occurs within 14 days of discontinuation of steroid therapy. So you use the steroid therapy, the patient went into remission, but just after 14 days of discontinuation of steroid therapy, then if these above features start appearing, then this is called as steroid dependent nephrotic syndrome. And lastly, there is steroid resistant, where there is no remission at all despite daily using of steroids or the prednisolone. Now coming to the management of the nephrotic syndrome. So the management first step here is high protein diet, obviously, because we are losing proteins from the blood vessels. Then for edema, we can do fluid restriction and give loop diuretics like furosemide plus spironolactone, but we have to be careful about the potassium level in case if we are giving spironolactone. Then for infection control, we can give antibiotics. For thrombotic complications or hypercoagulability, we can give low molecular weight heparin. And lastly, the drugs of choice are steroids or the prednisolone in nephrotic syndrome. So steroid, the doses is 2 milligrams per kg daily for 6 weeks, and then you taper the dose by 1.5 mg per kg alternate days for 6 weeks. So that this is the dose of steroids. Now you have to be careful while using steroids because of their side effects. So what could be the side effects? That could be cardiovascular complications like systolic hypertension, congestive cardiac failure. There can be endocrine complications like hyperglycemia, weight gain, decreased sexual maturity. GI complications can occur like peptic ulcer disease, pancreatitis, GI perforation, hemorrhage, and lastly there is also risk of infections. Now, if we see these side effects when using steroids, then we can use steroid sparing agents. Okay, so steroid sparing agents like levamisole, cyclophosphamide, tacrolimus, cyclosporin can be used in nephrotic syndrome if there is steroid toxicity like growth failure, hypertension, cataract, or when there is need for a high dose of prednisolone to achieve remission. We do not give high dose because if we start giving high dose, then the side effect will appear more frequently. Hence, we can use steroid sparing agents. Now on to the treatment of steroid resistant nephrotic syndrome. So for steroid resistant, we can use combination of immunosuppressive agents with prednisolone on alternate days and an angiotensin converting enzyme inhibitor ACE inhibitor or angiotensin receptor blocker ARBs. So on immunosuppressives, we can use calcineurin inhibitors like cyclosporin, tacrolimus, cyclophosphamide, uh, prednisolone with tapering doses like 1.5, then for 4 weeks, then 2.5 mg per kg for 4 months, and 0.5 to 0.75 mg per kg for 12 to 18 months. We can give methylprednisolone in replace with prednisolone. Then on ACE inhibitors, we can use enalapril, ramipril, and ARBs, we can use losartan, valsartan, and all these other kinds of drugs can also be used. Okay, so we also give IV albumin, which is limited to the symptomatic edema, symptomatic hypovolemia, marked ascites causing respiratory compromise. So that's how we manage nephrotic syndrome. Thank you.